IVF, it's very expensive right now, $15,000 or more, and not everybody can afford it, obviously. For instance, in the US, it's calculated that at least double amount of people would need this procedure, but they cannot afford it. For instance, other countries have 10% of the babies come from IVF. In the US, it's about 2%. So you can imagine that there is lack of access to it. This is driven by two factors. One, the embryology lab. It's still very manual, and it requires high skill on the part of the embryologists. And there are not enough embryologists. Everybody's looking for embryologists, roving embryologists from one lab to the other. And the other part is the doctors, the REs. Those are also, they don't train enough REs. Therefore, this also increases the cost of the procedure. What we want to do in our company is to automate the IVF lab. One, for economical reasons, but also because there is a lot of variability between person to person performing these manual procedures. There's lots of mistakes. Not every day you do the things in the same way. It's a Monday, it's different than a Thursday, the morning or the afternoon. Therefore, if you could automate the whole lab, then you will have better results and more consistent results. The three procedures that are more difficult and that need more qualified people are vitrification, ICSI, and embryo biopsy. Of those three, we think that embryo biopsy eventually will be substituted by methods that are non-invasive, such as non-invasive PGT, AI, and metabolomics. So we focus on the other two. Egg vitrification is very important because a lot of people are starting now to do fertility preservation. So they don't want to have babies yet, so they freeze their eggs now and then they can use it in the future. So this is one of the procedures that is growing the most now in IVF. And ICSI, once you have frozen these eggs, then you need to do ICSI to fertilize them. You cannot do regular fertilization. So those are the two most difficult ones, and so we started for... Nabil has done a great summary of the status of PGT before, but just to go over again, repetition, it's good sometimes. So as you know, there are several different methods or indications for PGT. The most common use, 90% of the PGT cases right now are PGT-A. And for that, usually we are using low coverage sequencing. Although you would need SNP arrays, SNP detection if you want to detect polyploidies. Then we have structural abnormalities. That is done basically with the same platform as PGT-A. Although again, you would need SNPs, to differentiate normal from carriers. And then we have PGT-M for monogenic diseases that you need a SNP array platform. And by that you do a haplotyping. So basically you phase the origin of each chromosome, and with that you can detect the mutation, and it's basically a pan test for any genetic disease. Although current SNP technology doesn't cover very well the whole genome, so sometimes you have difficulty with this system to find the mutation. Polygenic scores that were covered yesterday, and as I said, the only thing that it needs that we need to develop is PGT for de novo mutations. And for that, you really need to do analyze the whole genome, because these de novo mutations are not present in the parents. Well, they are not present in the blood of the parents. They are present in the gametes, and therefore you cannot detect them. You don't know what's gonna be affected until you do a whole genome sequencing of the embryos. So PGT-A and also PGT for structural abnormalities, as you know. There is an increase in chromosome abnormalities with advanced maternal age, and most of this is produced by aneuploidy. And we said some time ago that if we select for aneuploidy, we will improve implantation rates. This is basically true by if you look at when you transfer a euploid embryo, they more or less implant equally well at any age compared to non-PGT. There have been a bunch of publications right now, and most of those randomized trials in patients over 35 show an improvement in results. But however, this is not the case for patients under 35. This could be for several reasons, because you still see 20% chromosome abnormalities or more in young patients. But it could be the study design in some of these studies. For instance, they use platforms, as Nabil said, that may produce more mosaic signals, and those embryos at the time of those studies were not transferred, so you are eliminating there maybe 20% of the embryos that could have been transferred. And those, there is a higher rate of mosaicism in younger patients, so that could be one of the reasons, and the other could be the effect of the biopsy. Still, if you look at SART data, even in young patients, you see a significant improvement in results. And now PGTA is performing over 50% of cycles in the US, as the late SART data shows. So basically, PGTA increases implantation rates per transfer, reduces miscarriage rates. It increases live birth rate per transfer, reduces time to pregnancy, and enables confident single embryo transfer. Obviously, what it does not do is to create euploid embryos. It's a selection technique, so if you don't have any, you cannot improve anything. And obviously, it does not improve cumulative pregnancy rates, because if you transfer every embryo one by one, you should get the same results, or worse if you're doing some damage on the embryo during the biopsy. PGTM has gone through an evolution of several generations. At the beginning, we just detecting the mutation and link markers. The problem is that if you don't have link markers that are close to the mutation, then you could have misdiagnosis by recombination. The second generation is karyomapping, in which you're phasing the chromosomes, and that with that you can identify if the chromosome comes from one parent or the other, and which chromosome of the parents, and then you can know if that chromosome has the mutation or not. And the next generation, it's basically sequencing and haplophasing. So now there is a tendency, there is a bunch of papers trying to combine all these techniques into one. And basically, the problem that we have is the amplification. So there are several methods of amplification. The most common use for copy number is basically PCR amplification and like methods like sureplex and picoplex, but those are very noisy. You cannot detect very well SNPs. The other is basically amplification target to SNPs, such MDA and RepliG, but those are not very good for copy number. And then now there are new methods such Malbach, Lianti, PTA, that seems to be much more faithful in detecting SNPs and also copy number. So there are several methods now for haplotyping, basically, again, identifying the chromosome of the parents that has the mutation. You could have karyomapping, haplorhythmices, all of those that use SNPs. Others use sequencing, and other methods use a combination of both, such as PGT complete or PGT-seq. Some of them are clinically used, although there are not a lot of data on it, and especially there is not a lot of data on using it for all these indications at the same time. So, for instance, you have low-pass sequencing. It can detect aneuploidy and mosaicism, but it cannot detect polyploidy, balanced translocations, inherited mutations, and so on. You have SNP arrays, which they detect poorly mosaicism. They don't detect mutations, but could detect all the other things that we want. Sorry, I cannot even read this. Can I see the screen here, because I cannot see it? Okay. And basically, then you have all these haplophasing methods that can detect everything, with exception of de novo mutations. So for de novo mutations, we really need to sequence the whole genome. So why we want to detect de novo mutations? Well, de novo mutations, as I said, you cannot detect them in the parents. They are originated in the gametes, and on average, we have 74 de novo mutations per embryo. Some of them will be pathogenic, and the only way to detect them is by whole genome sequencing. And we want to detect them because, in addition that they increase with paternal age, for instance, you would see that there is a risk of 3.5 times autism with advanced paternal age, 27% risk of bipolar disorders. These are very severe mutations that we want to detect. Usually they are not affected by lifestyle, like polygenic genes score. So, and they are much more common than inherited mutations. So really there are 10 times more de novo mutations affecting babies than inherited diseases. But we're not detecting them right now. They could be single point mutations, but also they could be copy number variants. Those are larger mutations. They involve 500 base pairs or more. And about 1 to 2% of conceptions carry one of them that are between 100 kb and 10 megabases. Obviously, some of those will be detrimental. Interestingly, the more copy number variations you have per embryo, the higher the predisposition to have autism. And then, as I said before, yes, aneuploidy can detect it's causing this decrease in implantation potential, but really after we select embryos for an aneuploidy, you still have 30% or more embryos that don't implant. Some of these could be caused by the transfer procedure, but obviously there has to be a proportion of those that are produced by de novo mutations. There have been 3 methods right now to assess de novo mutations. The first, we developed it with Peters et al. From Complete Genomics. This was a platform, it doesn't exist anymore. But basically, it sequences, so you fragment the DNA and then you sequence each fragment independently. And then you can compare them. So if you have artifacts, then you would detect these artifacts. So it was a way of eliminating the problem of the amplification. The other one is by Xie et al. It's been published recently using a new amplification method, PTA. And then Nick Murphy et al. Developed a platform basically using bioinformatics to just using regular amplification at high depth, 30 to 50x, to clean all the artifacts that are produced by the amplification. Oof, what's going on? Something happened here. So the first, as I said, the first method was by Peters et al. It denatured the DNA and then dispersed it into 384 wells. About 5% of the DNA of the embryo was in each well. Then you amplify it, barcode it, etc., and then you compare it. And This was done at 23 coverage, and it found thousands of de novo mutations, of which about 30 of them were at the time identified as pathogenic. Here, it didn't develop filters to select which one were pathogenic or not. So basically, this was just the method, how to do it. I think it was very neat, but then you need a lot of bioinformatics on the back end, which at the time didn't exist, to clean the data. The other methods is primary template direct amplification. Basically uses MDA, but then it adds an exonuclease that makes smaller amplicons. You are amplifying more of the original amplicon. So if there is an error in the amplified product, you don't read it. So this reduces the errors of amplification, and it has much higher fidelity than other methods. If you could see on the bottom, one method compared to the other, one is much more noisy, MDA, than PTA. With that, you cover about 90% of the genome very well. And they done just a couple of experiments with embryos, so 2 biopsies versus whole genome versus the whole embryo. And they got 96 genome coverage at 14 depths. Again, they detect 3 million SNP variations. 96% of them were concordant with the rest of the embryo, still 70,000 discordances. But they were repeated in both biopsies. It can detect aneuploidy, inherited and de novo mutations, polygenic gene scores, and so on. Again, then you need a filtration method to know what to do with these 70,000 SNP variables. So this brings us to Murphy et al. Method. Basically, it uses a regular MDA, and then it sequences the parents at 30 depths and the embryos at 50 depths. And then it has a bunch of filtration methods to detect false positives. And then once you have these de novo mutations identified, then it annotates them with 50 different sources, just to report only the ones that are going to be detrimental and pathogenic. It can detect de novo mutations, inherited mutations, aneuploidy, translocations, basically everything. This is just a graphic of some of these filters that they use. This is for SNP defects with less than 10 kb, and this is for more than 10 kb. And then uses all these databases to annotate these mutations. And all this is an algorithm that he's using. And basically, without his system, you get between 200 and 500 kb false positives, so more than with PTA. Obviously, we want to try PTA to see if you can reduce it and then apply this filtration. Obviously, this is way too high. And all these errors are the typical ones produced by MDA. But with his filtration method, you can decrease these false positives by more than 90%. The validation that he's used so far is use Genome in a bottle. This is a very well-known genome. It's been studied in depth. And then compare the genomic DNA to amplified DNA and assess. Well, then you do the analysis, and the no mutations are calculated before filtering, but before annotation, and then annotation happens. Also, what they do, once you have identified this Genome mutation, you can reconfirm it by Sanger. So you have a second detection of the mutation. So we calculated the positive predictive value, negative predictive value, sensitivity, and so on. I'll show you now. Well, this is how we calculated it, obviously. And so for positive predictive value, we had a 98% and 93% correlation with genome in a bottle. So here we're comparing genomic DNA to non-filter, so before the filtration, and then the genomic screen filtering. For negative predictive value, we have a 99.992%. For sensitivity, 92%, and for the SNPs, and 84% for indels. Specificity, again, very high, 99.998. And for accuracy, again, 99.997. And then false discovery rate, about 2.93. And false positive rates, 0.2%. So this is in summary for SNPs and indels. So it's very, very highly accurate, but then once you detect an embryo and you say, well, this is abnormal, has this de novo mutation, you can then, by Sanger, reconfirm. You don't need to do a biopsy, just reconfirming with Sanger. So you have a second point of analysis to confirm the mutation. So, for instance, as I said, with pre-annotation, so before all these filters, you have 2,000 to 3,000 de novo mutations, but after the filtration, you only have 1.17 pathogenic de novo mutations per sample. And after that, as I said, you could still do another more stringent criteria about the penetrance of the disorder, its inheritance, age of onset, and so on, and report it or not. If it's, let's say, it's late onset disease, maybe you don't want to report that, and then you can retest it by Sanger. So it's not that from a whole cohort of embryos, everything is going to be abnormal. Basically, some of those will be pathogenic, but maybe it's not so important. Everybody has defects here, right? We need now what we need to do is obviously do more cases. Also, obviously this is going to be expensive. So what we will do is first to do PGTA, so anything that is normal, then you can do a PGTA with whole genome sequencing. And the cost is decreasing day by day. Right now, this new machine by Illumina, it's providing the NovaSeq X. It's providing genomic sequencing, whole genome sequencing for $200. So if you count the cost of a PGTA, $100, and then this one, $200, is not so expensive at the end of the day. So next steps. Sorry, this is not in the right order. So we want to. There are still several. Sorry, let's pass all of them. So there are still several things that we want to do. So we want to try different amplification methods to see if we can improve even more the accuracy. Do experiments between biopsies and whole genome and whole embryo. Obviously, we're going to do Sanger concordance. And define better the indications. So obviously one of the, I see at least 2 or 3 populations that will be at the beginning indicated for that. One is advanced paternal age, because de novo mutations increase with advancing paternal age. Consanguineous populations, for instance, Middle East, that will be very useful there. Even if you have, let's say, if you do PhD for monogenic diseases there, because there could be de novo mutations, you would not detect the de novo mutation. So if you're transferring recessive, or sorry, if you transfer an embryo that has one of the mutations but not the other, there could be still a de novo mutation there. So for these consanguineous groups of people, this will be very indicated, and obviously later on everybody. So in conclusion, there are now many tests that could do comprehensive PGT. But for de novo mutations, the only way to do it is with whole genome sequencing. Thank you very much. If you have any questions, specifically very technical questions, please contact Nick Murphy, who's the developer of the test. Thank you.